Hello everyone, my name is Dr. Yesudian, a consultant dermatologist based in the UK. In this video, I will look at Pityrosporum or Malassezia folliculitis, otherwise called fungal or yeast acne, a condition that is fairly common and is often mistaken as acne. The terms Malassezia and Pityrosporum are used to denote the same organism. I see Pityrosporum folliculitis fairly frequently in clinic, and as it is asymptomatic and mild in most, active intervention is usually not required. However, it can be fairly troublesome on occasions and needs to be recognized and treated appropriately to bring about remission. Malassezia and Candida are yeasts found in the skin and mucosal membranes respectively. The physiological difference between them is that Malassezia is dependent on the skin surface lipids. Malassezia colonizes the skin in humans beginning immediately after birth and is reported to vary in incidence from 75% to 98% on the skin. It lacks the ability to synthesize long-chain fatty acids and therefore requires exogenous sources like the skin to use them as sources of energy and to build its structural components. Pityrosporum or Malassezia folliculitis was first described in 1969 by Weary et al., who noted an acneiform eruption associated with antibiotic use. It frequently affects young and middle-aged adults and is rare in childhood. In adolescents, it can often coexist with acne vulgaris. The condition is thought to be more common in tropical climates. Malassezia folliculitis develops when the local balance in the pilosebaceous unit is disrupted by host-associated or exogenous factors. The following conditions may contribute to the development of Malassezia folliculitis. Firstly, disrupted immune response as shown by an increased prevalence of Malassezia folliculitis in immunosuppressed individuals. Secondly, increased sebum production as occurs in pregnancy or with underlying acne. Thirdly, skin flora alterations following wide-spectrum antibiotic use. And finally, skin occlusion by cosmetics or tight-fitting clothes. The yeast used its own lipases to hydrolyze triglycerides from sebum into free fatty acids and use them as a lipid source for proliferation. Folliculitis develops when the balance in the pilosebaceous unit is disrupted. The subsequent yeast overgrowth leads to inflammation of the follicles through a multi-stage interaction of the yeast with the keratinocytes and the immune cells in the skin. Clinically, Malassezia folliculitis consists of monomorphic dome-shaped papules with a central dell representing the follicular pore. The papules are usually about 2 to 4 millimeters in diameter and may be interspersed with small pustules demonstrating minimal inflammatory response. In male patients, lesions appear predominantly in the back in 88%, in the shoulders in 57%, in the upper portion of the arms, and to a lesser extent on the chest and the back. In female patients, the face is the most common site in 81%, followed by the shoulders in 34% and the chest. Itching is a regular symptom found in more than half the patients, and excoriations are not uncommon. The condition is often accompanied by increased seborrhea or oiliness and coexistence of dandruff and pityriasis versicolor. Malassezia folliculitis, especially in the adolescent, can be misdiagnosed as acne and can be confused with bacterial folliculitis as well. Differentiating it from acne vulgaris is important as the antibiotic treatment may alter the cutaneous flora and exacerbate the disease. The two can be differentiated by the lack of response to oral and topical antibiotics, absence of comedones, and often the pruritic nature of the lesions. Here is an example of Pityrosporum folliculitis that looks like acne. Fine monomorphic papules and pustules on the forehead extending into the hairline with mild associated scaling of the eyebrows and on the upper chest. Some authors report a more polymorphic disorder with nodules or cysts, but this phenotype is usually described in tropical climates where there are more severe cases. Atypical presentations of Malassezia folliculitis, as seen in this publication from the American Academy of Dermatology, include eosinophilic folliculitis-like, pityriasis lichenoides-like, prurigo-like, and mucinosis-like morphologies. Treatment includes topical and systemic anti-yeast medications. Topical ketoconazole, either as a shampoo or cream, is effective in about 85%. Topical 2% selenium sulfide, zinc pyrethron, 1% clotrimazole, and topical econazole can also be beneficial. Oral ketoconazole, 200 milligrams a day for 2 to 8 weeks, is helpful, but this medication is not available in Europe at present. Systemic itraconazole, 100 to 200 milligrams daily, has been used for 1 to 4 weeks with a positive response in 80 to 100%. And fluconazole, 100 to 200 milligrams daily for 1 to 4 weeks, has a clinical effect in 80%. In resistant Pityrosporum folliculitis, low-dose isotretinoin at doses of about 20 to 40 milligrams a day or even 20 milligrams 3 times a week is very helpful, and this is something I use quite often in clinical practice. There are a couple of reports of photodynamic therapy being effective when used 3 times every other week for a month. Many studies report relapses after treatment discontinuation. These patients may benefit from additional preventative topical regimes. So what are the learning points? Malassezia folliculitis is a clinical condition that requires timely, accurate diagnosis and management. It may persist for many years if it is misdiagnosed as acne vulgaris. The condition requires a high index of clinical suspicion on initial presentation, especially if itchy and monomorphic skin lesions are present over the trunk, extremities, and the face. Administration of antifungal medications results in dramatic improvement of the condition. I hope you found this information helpful. Thank you for listening, and bye.